Yeah, way you're giving us hatutakava vitu mingi. I was thinking we just do the questions maybe. Yeah, then maybe from the questions ukipeana answer maybe it can lead to another thing hivyo hivyo. Like let these case studies guide us. Yeah, because I'm imagining we need to like cover everything you've said, then again go to that question. No, no.
Thank you for your view. I don't know what others' views are, but I saw it wise that we just briefly talk about it and then, okay, we can use the question to rethink. But even using the question takes longer because you have to rethink the question and
Okay,
yes.
if it's about getting the summary of it, okay, you can maybe take us through like mbio hivyo. If you start sijui give us this, ita take time kidogo. So maybe if you have some notes or an idea, you can just take us through. Then you start on the question, if possible.
Okay, well noted. I'll just be giving the summaries where possible and then we go through the case and we touch on the important areas. Thank you. That's a very important consideration. So I was talking about malnutrition. By definition, it is a medical condition that that results when there is a deficiency or there is a deficiency of either of the nutrients that an individual is supposed to have. It can be undernutrition or malnutrition. It can be under or the opposite of under. So either excess or low nutrition. So another thing about nutrition is the classes. We usually have this some, mom, and moderate malnutrition, severe, and that is moderate and severe, mom and some. And then you need to know about classification according to the mark. You classify according to mark. Mark it if it is less than 11. Is it 11.5? If I'm giving the, let me, yes, you'll be reacting so that I know whether we are together. I'm just summarizing. So mark if it is less than 11.5 centimeter, that one you classify it as severe. If the Z score, WZ score is less than 3, severe, mostly in children less than 6 months. And then another thing that can help in the diagnosis is clinical features. The clinical features that you need to get is the edema, you know, the skin usually the skin it's flaky pale, it can be pale in color, pale. Then the hair can be brittle. There is hair changes. If you look at the child, there is hair changes. Some children can present with big head. What is the medical term for the big head? You can type in the chat box. Some words are escaping my mouth. Those are the clinical features that you need to diagnose malnutrition. And also you need to check on the danger. We talk in the pediatrics, we usually talk of the danger signs. The mother will come that this child is not breastfeeding, this child is vomiting, this child is having diarrhea continuously. So those are the danger signs should also be taken into consideration. That is for you to diagnose a malnutrition. And also check of who does the child stay with. Is it the mother or the grandmother? For you even to judge things with nutrition, how is the nutrition of the child? Is the child staying with the maid? And even cases where the child stays with the maid and both parents are working, it can also lead to that. So that is a brief note on the clinical features and the things that you need to diagnose malnutrition. Additional points you can put in the comment section or at the end. Then another thing you need to know, now we have diagnosed malnutrition. We need to manage. Before management, the investigation on which you guys will add up, there are some investigation that you need to know in malnutrition. One of the investigation, you can do UECs to check on the kidney functions. Another investigation, you can do a CBC to check across for the infections, to check for the HB level, so that you see if there is need for transfusion. And then the other investigation you can do LFTs to check for the liver, how it is functioning. And in case the child has big head, hydrocephalus, you can do a CT scan, to check for other things. That's just to mention but a few. Another thing, after investigation, you need now to manage, because you combine the history and the investigation for you to come up to diagnosis, and then you manage the child. There are usually 10 steps in the management. And in the management of severe acute malnutrition, number one, when the child comes to you, maybe the child is breathing fast, you need to apply, do not tense, apply ABCD as usual in medicine emergency. After applying ABCD, and then you start the steps. Step one is usually you check the sugar level, the blood glucose. If it is less than 3, you give dextrose, 5 ml per kg, 10% dextrose. But if you don't have the glucometer, there are clinical signs of hypoglycemia you can just note. There is the tone is lost, the child is unconscious. You can give glucose. But if the child is unconscious, we don't give oral glucose. Only if the child is AVPU is at verbal or alert. That is step one. Hypoglycemia, you give glucose. You give dextrose, 5 ml per kg. Step two is for hypothermia. This child has, we are worried about the temperature. If it is less than 35 degrees Celsius, you can use blankets. You can use warm bags of, when you are giving IV fluids, you use warm fluids. You can use a heater there in the pediatric ward. That is how you manage hypothermia. And then these people are joining. Let me set so that they can just join freely. I have not set that. Before we proceed, kindly. Yeah. Whatever I'm forgetting, you just let me know in the chat box. Before we are getting to our question, just go. I'm not able to set. I'm poor at computer. Okay, number 3 is you check for dehydration. How do you check for dehydration? Skin pinch, you can check the anterior fontanelle. Is it sunken? Is it sunken fontanelle? You can check for the eyes. Are they sunken? So if it's dehydration, what do? You classify the dehydration. If it is shock, you use IV fluid. If it is shock, if in shock, use IV fluid. If not in shock, you use what we call Risomol. Then transfuse. If the HB is less than 4, that's why I said you do a CBC. You transfuse all blood, not packed blood. That is 10 ml per kg. And then you can add on when you are transfusing, because there is that imbalance. You need to also consider giving a lot of fluid can lead to edema. You give Lasix, furosemide 1 mg per kg. That is step 3 about dehydration. You check for dehydration because of the child head. Most of them present with diarrhea, and if he has diarrhea, can lead to shock. So you do manage that diarrhea by fluid. Then step 4, we are worried of electrolyte imbalance. How do you manage that? You can use what you call F75. If not available, you can prepare oral potassium 4 mmol per kg. But most of it is available. If not available, then you go to the alternative. And then you are warned never to use. We are not using that Lasix for edema. We are only using Lasix when you are transfusing, because you are adding fluid. Fluid is just, blood is still fluid, part of fluid. So you never use Lasix for edema, Now, then step 5, I hope you have got the last step. Then step 5, I'm just going through. Step 5, you need to know, because we are worried of infection, you start with expengenta, and you give it for 5 days. If improved, the child can take orals. you will consider with, will continue with what? The amoxicillin. Mostly they give DT, amoxicillin DT for the 48 hours after 5 days of expungenta. Then you can give nystatin for the oral thrush, mebendazole after 7 days of treatment. Then you can give for the eyes, you check for the eye. If there is an infection of the eye, you give tetracycline ointment. That is number 5, step number 5. Then step number 6, but these steps are more or less, they are conjoined according to the protocol. But if you get the 10 step clearly, you can be able to differentiate. Like you giving, then the next one is you correct micronutrient deficiency, because when the child is having diarrhea, and then this child has not been feeding. Actually, the malnutrition is this person is not getting the enough nutrient that is required inappropriately. Vitamin A should be given on admission on day 2 and 14. Multivitamin for at least 2 weeks. Then remember we are giving F75. If the child now has caught up, is now stable, you continue with what? F100. Continue with F1. You don't start with F100. F75 is for stabilization, then F100 is for pickup, yani for continuation after stabilization. You guys will shed me more light about F100. How is it prepared? What is the dose? What is the, how do you prescribe it? And then you can give folic acid 2.5, multivitamin first before folic acid, then folic acid 2.5, iron only when the child is gaining weight. You only give iron when the child is gaining weight. And then also you encourage the mother, you watch for the growth of the child and other things. So that's the management in short. Then complication, you guys, you need to tell me in the chat box. Complication of malnutrition. I think in the chat box, complication of malnutrition. We are going to the question. I hope I jumped 16 minutes. The question we are going to rush through it within a spike of 5 minutes, and then we answer. So that is complication of malnutrition. You should know it. Then the DDX. What is the DDX of malnutrition? Thank you, Emela Damaris. Complication, we have infection. We have somebody has talked about. Yes, complication, infection, anemia. Anemia is a complication of malnutrition. Most tested question is on SAM, severe acute malnutrition. Differential, Dory has given us marasmus, kwashiorkor. Millicent has given us a complication of hypoglycemia, very good. That's why we need to check on sugar. Dehydration is a shock. Actually, you just need to say shock. Shock is a complication. There in infection, you can be too good to say sepsis. Sepsis feels good and mature compared to infection. You can talk of all that. And also another DDX can be child neglect. The child is neglected. The child can present with those clinical signs of malnutrition, but with even signs of that this child was being burned by, refeeding syndrome. I think Newton care. You'll get us what is this refeeding syndrome. I'll get back to you. You'll tell us about refeeding syndrome. It usually occurs because after this child has now started catching up, when you're giving those feedings F75, I think it comes there. Kindly find out so that you'll be able to elaborate to us clearly what is that refeeding syndrome. So I hope I've summarized on malnutrition. You can react so that we know if you are getting to the questions, to the case, so that we are able to discuss together and kindly let's participate. So we have our case there. There is a mother, we don't know the name of the mother, brings an 18-month-old boy to the outpatient department where mostly clinical officers sit. She says he has swelling of both feet for 3 weeks, has lost hair. Full stop. He was weaned abruptly 2 months ago to porridge only after mother got new pregnancy. You have seen there. On triage, weight is 7.2 kg. Remember, our child is 1.5 years. So you relate. Length is 76 centimeter. Mark tape is 11.0 centimeter. That one you relate in your mind, the normal mark. Temperature is at 35.8 degrees Celsius. You relate the normal temperature. We will consider if it's hypothermia or hyper. Edema is ++3. Pitting both feet and hands. And then hair is thin, reddish, easily pluckable, skin with dirty patches, peeling off groins and paddock. Child is irritable, miserable, not interested in playing. Actually, that those children don't play. Mother says he had watery diarrhea 5 days for 5 times a day. That's 5 episodes for 4 days. Vital sign heart rate is 126. You need to relate, is it increased or decreased? Respiratory rate is 40. You need to relate. Capillary refill is 3 seconds. You need to relate. Then there is a weak pulse. Thank you, Newton, but your screen has gone off. I was just reading there very well. Now, hope all of you you can read it through the case. You rethink through the case. Let me allow this individual to join. That's this man from Tessoland just joined us. Okay, thank you. Welcome, Malvin. We have just briefed ourselves on malnutrition and we are going through the case study in the group. I can still see it. Newton, try your network is still, we're not still getting it. Let me get the question on the other side so that you are able to respond and save on time.
We are seeing it, Daktari. You're the one who is not seeing it. Maybe it's your network.
Okay, I'm not able to see it on my side. Okay, what does the first question read, Edwin?
Now just Newton has just closed it right now.
Okay, let me get it on WhatsApp. Somebody can read for us the question. Email Damaris. Question 1.
Okay, I cannot see it.
You don't have it in your WhatsApp. Project it kidogo tu.